Hello, this is John Kanlopoulos, our center here in Athens, Greece, LaserVision Aperture Surgery Center. We're watching a series of cataract procedures, unedited at 8 times speed. We can tell here there's pseudoexfoliation. We're planning a toric intraocular lens. These are consecutive cases from an operating day for me here in December 2024. Manual, curvilinear capsulorhexis, hydro dissection, careful, especially in pseudoexfoliation, as well as a lot of care taken not to push the lens too much. This is where the second instrument plays a significant role in order to balance the forces when our phaco sculptor is pushing, quote unquote, on the lens. Cataract is out. Irrigation aspiration very careful here as the cortex is quite cloudy. Make sure not to grasp any capsule, and also very important not to pull in towards the center but sideways, so to share the forces, the vector forces sideways on the zonules. Toric intraocular lens. Our go-to lens is the Clarion by Alcon. Continues the perfect material, the Acrosoft material, with less glare and no glistering. A watertight incision, case number 2, T3 lens here. You probably see every single case being toric. We have a record of over 90% toric intraocular lens placement globally, as we measure preoperative astigmatism with several keratometric measures, and we aim for half a diopter with the rule in all cases. So we even put a toric lens in a patient that has 0.25 diopters against the rule as native cornea astigmatism. The theme is the same, divide and conquer technique, some mixed with pulling a hemimeridian here. Hydro dissection will push the hemimeridian out, back chop the half, and go on and on. Always complement with viscoat. We use it copiously in order to protect the capsule. Very sensitive part when we're left with the last quadrant to grasp part of the posterior capsule. And the split aspiration here with my left hand. My paracentesis is 1 millimeter, and the main incision 2.75. Again, the Clarion T3 lens. Nothing really spectacular here. Everything is going by the book. Under the lens, remove viscoat and methylcellulose that was used to implant the lens. Over the lens, very careful. Rotate the lens on the correct axis. Hydrate the wounds rather. Make sure the lens is in place. And once the wound is watertight, we're home free. At T4, we're going step by step. T2, T3, T4, as if this was choreographed. Again and against the rule astigmatic case, obviously with more astigmatism, fuzzier lens. My incision always at 135 degrees, and this is why our formula on calculating the IOL is close to perfection. It's very rare now, even in post-refractive surgery eyes, to have a refractive surprise. And in New York, we do use the light adjustable lens. It's not available in Europe, where these cases are from, but we see very low need for it, maybe one enhancement a year. Divide and conquer 4 quads. We can see here there's a more significant cataract. Nevertheless, we stayed with under 100 joules of total energy, and again replenished the viscoat in order to protect the endothelium, no endothelial problems. If one practices this extra step that takes a few seconds, again very careful in removing the cortex with my right hand, and then lefty here with my split aspiration, fill the capsule bag. Again, our Clarion toric T4 in this case, intraocular lens folded, unfolding in the capsule bag, aspirating from under the lens carefully not to grasp any posterior capsule. Over the lens copiously, a lot of the viscoat material gets stuck on the endothelium. In a patient with compromised outflow facility the next day, we may have an unpleasant IOP spike back to a T2 lens here, oblique astigmatism, and again, almost copies of the first procedure, always 135, incision, and at the 180 or 0 degrees, if you may, a manual capsulorhexis, softer lens, will split in half. We'll lift it, back chop, and aspirate. Lens is gone. Irrigation aspiration now, and polishing the posterior capsule carefully. We're going with the lefty split aspiration. Irrigation is staying with the right hand polish the capsule here, fill the capsule bag. And again, here's our Clarion, a T2 model here in the bag. And I left these cases unedited on purpose in order to get a good feel of the time spent for each procedure. I do place myself the IOL in the cartridge. I make sure that the lens unfolds, all haptics, lens is centered, axis correct. I'm coming back here in order to use myoclone and attain a little bit of meiosis. This was a suspect KCN case. This is a post-LASIK case back in 1998. These are some of the first LASIK cases I did in Greece. One of my cases, obviously if it was a female, which I think if this is the case here, we know that they develop cataracts before their 60s, and we advise um, on the same token, most younger ladies that are over 5 diopters myopic in Greece especially, that our experience have been that regardless if they do laser or not, we expect them to develop significant cataracts, likely in their 50s. We've done many in their 40s. Again, the same theme here, lefty aspiration, irrigation stays on the right with a main probe, polishing the capsule, and filling in with methylcellulose. Patient desired to have some myopic correction, so we're aiming dominant eye minus half, non-dominant minus 1.5, and this gave us at the end of the day 20/20 combined uncorrected distance visual acuity and J1 near visual acuity without any problems in depth of vision or balance with the two eyes. This is the other eye of that same patient, a little more cataract here, and surprise, surprise, this is probably the one case out of 10 that the keratometry and the IOL calculation based on my incision at 135 did not produce a toric lens. So a little bit more dense lens here, again divide and conquer. We'll complete the hydro dissection, pull out the half back chop, cataract is out, IA, and we'll go in again with the lefty split to remove the cortex under the main incision, carefully polishing the capsule, fill with methylcellulose, a little more polishing here, make sure that the central part of the posterior capsule is intact. And again, this is a Clarion non-toric, very well received in my practice. I did the transition within a week from using an Acrosoft, a spheric toric IOL for over a decade, close to 2 decades. And a more dense lens here, against the rule of astigmatism. As you can see here, technique remains the same, everything the same. A manual capsulorhexis using Utrata, very well controlled. Again, dilatation is attained just with 5% neosynephrine drops and 0.5% tropicamide. The lens is quite dense. We're using the signature device set at 80% phaco power. And again, copious viscoelastic viscoat, and carefully bring everything to the center of the pupillary aperture, away from the cornea. Back chop here. And you saw that I replenished the viscoat prior to removing the last 2 segments of the lens. And again, IA from the main incision and lefty from my paracentesis. And we'll complete the procedure. Everything looks back to normal. Fold the lens. Here we go. Significant astigmatism in this patient. Our lens has carries over 2 diopters of astigmatism. Under the lens, over the lens, irrigation aspiration. Center the toricity of the lens to our preoperative marks, and as you can saw, a T4 in the other eye of that same patient. As you saw, the patient comes in with a 6 o'clock mark, which is easily performed on the slit lamp. And the 6 o'clock is the lowest part of the limbus when the patient focuses straight ahead. So it's very easy to place as we come from the lower level. The patient doesn't even see the marker. They barely feel it without even anesthetic. And it's very easy to notice during the procedure. Again, divide and conquer technique. We have 4 quads, higher aspiration, And again, once the two first quads are gone, I'll replenish the viscoat, our go-to viscoelastic for the divide and conquer, or the removal of the nucleus with phaco, so to speak, for decades now. And irrigation aspiration with my dexterous right hand and lefty here, staying with my right hand with the irrigation, viscoelastic, polishing the posterior capsule, and I will personally fold the lens, make sure the haptics are placed nicely, and come in, remove. And you can see that sticking with the routine makes everything more predictable. A fantastic result here. We aimed for plan on the dominant eye and minus 0.75 and non-dominant. So better than 20/20 at distance uncorrected and a J3 at near. This patient was a hyperope, the one we just finished that second eye. We're in a new patient now. Oblique astigmatism here, same technique. Main incision, paracentesis, cystotome to initiate a continuous round capsulorhexis, hydrodissection, hydrodelineation, spin the lens, viscoelastic under the lens. This is a softer lens, obviously, and we'll come in and take the lens all together. Back chop with our Sinskey hook. Privileged to have met Bob Sinskey back in the day when we were launching the Dodic neodymium YAG phacolysis. Our work in Europe and coordinating several centers was enough to get a 510K for this technology in the US in the late 90s, early 2000. With that technique, we were also able to perform the first cataract procedure with a 1.6 millimeter incision. So we broke back then in 1999 the 2 millimeter barrier here in Athens. And of course, nanosecond laser has had its fans. It has not replaced phaco, but it did push phaco to come into lower energies. And none of these cases seen today went over 100 joules. Most of them were under 30 joules in total energy used. And we're seeing here another case yet to repeat the same protocol and see step by step the special care. And although these run eightfold in speed, you can see where an experienced surgeon's attention is more on the capsulorhexis side, and experienced surgeons will understand why. Again, bring this lens all together in the pupillary aperture and remove. Come in, IA, there's almost no cortex left, but polishing the residual cortex, a younger patient here. And again, our Clarion Torque intraocular lens, folding, placing the capsule back, and unfolding. So I was saying that even considering the fact that we're seeing things running eightfold in speed, you can see where the attention is spent the most on the capsulorhexis, replenishing the viscoelastic once we're left with smaller pieces of nucleus in the capsule bag to avoid any inadvertent flapping of the posterior capsule, and nicking it with our phaco probe. Also very careful in our IA. Also very careful on the centration, hydration of the wounds. If any of these wounds leaks, I will not hesitate into pulling out a tendon island and placing a stay suture. So this was our surgical day. I hope you found it interesting. This is John Kanellopoulos from our center here in Athens, Greece, the LaserVision Surgery Center, signing out. Thanks so much for your attention.